So, hello everybody and welcome to tonight's webinar when award-winning cardiovascular nurse Rosalie Magboo presents the long-awaited results of her PhD on the psychosocial effects of a diagnosis of aorto-vascular manifestations and Marfan Syndrome. Integral to and facilitating her research has been Gareth Owens, chair of the Aortic Dissection Awareness UK and Ireland charity. Gareth is a great friend of the Marfan Trust, and this is our first official adventure together, so we're very excited to be collaborating tonight. It's a short webinar crowded with fascinating content, so I'll keep this brief and sweet. Rosalie will present her results, after which there'll be an opportunity for questions, and Gareth will MC this session. All that is left for me to say is that it would be great if you were to remain muted throughout the presentation until if and when you have a question to ask afterwards. And we're recording this webinar, so if you're feeling shy, then simply switch off your video icon. Thank you, and it's now over to Gareth.
Thanks, Victoria. It's great to be here running this webinar together with the Marfan Trust. I, as well as being chair of the National Patient Charity for Aortic Dissection, you can see our website up there if you want to know more about us. I am a Marfan Syndrome patient, and in 2016 I had an acute aortic dissection and was one of the first aortic patients treated in the new Bart's Heart Centre. So I was a very lucky fella, and I've had a great outcome from that because I was cared for by lots of wonderful people at Bart's, like Rosalie, who is ICU matron in Bart's Heart Centre. And it's been my privilege for the last 4 years, I think, to work with Rosalie on her PhD. And I'm just so inspired that somebody of Rosalie's professional standing should choose as her PhD topic our disease, and trying to get inside my head as a patient, or our heads as patients, and understand how we respond to a diagnosis of aortovascular disease in Marfan syndrome. So that's what the session's about. I know Rosalie's got a fantastic presentation for you. So if you can keep yourself muted while we listen to Rosalie, we'll have a set of questions at the end and plenty of time for discussion. And that's what I'd like us to do, is just kind of hear what Rosalie's got to say, and then have a nice open discussion when I'm very keen to hear from all of you. And we've got a really big crowd on tonight about what you think about Rosalie's research, what questions you have, whether it rings true with you in terms of your personal experience of the disease, or anything else you want us to discuss. So Rosalie, welcome. It's great to have you here. Over to you.
Thank you so much for the great introduction, Victoria and Gareth. I'm just going to share my screen, if that's okay. Right. Can you see my screen?
Yes, we can perfectly.
Yes.
Thank you.
Perfect. Okay. Oh, sorry. Oh, 1 second. Sorry. It's just all the... I cannot see my screen, actually. Just strange. Okay. All right. Anyway, thank you. Right. Okay. Thank you again for the wonderful introduction from Victoria and Gareth. So again, I would like to thank Marfan Trust and Aortic Dissection Awareness UK for organizing today's event, and for the whole group for giving me the opportunity to discuss with you the result of our work at Bart's, and to actually tell you my story on how I get involved with this work. So why and how it started? So as Gareth said, I was a senior sister in intensive care unit at St. Bartholomew's Hospital when I first started to get involved in this work. In 2016, 1 year after the merging of the three hospitals to form the Bart's Heart Center, we set up the Aorto-Vascular service, and Gareth, whom you all know, was one of our first patients, as I said earlier on. As a regional referral center, we saw an increasing number of patients with aortovascular problems coming to our center, and many of them had aortopathy problems, who often have a more complicated operations. So as most of you knows, due to their condition, some of them will be coming to us for 2, 3, or even more operations. In looking after these patients, I've noted that a lot of them were actually anxious, they can be depressed, and many may have some form of psychosocial issues that they're presenting when they come to us. Although we provide an excellent medical care at BARTS, I felt that we were missing something in the care of these patients, particularly on the psychosocial aspect. And as a nurse, our care doesn't end when we discharge our patient from intensive care unit. And in my quest to find an answer to my questions, I did a lot of literature search and found that there's very little evidence on the health-related quality of life and psychosocial effects of living with Marfan syndrome, which we all highlighted in that editorial. As a result, I was really inspired and took on the challenge of conducting a research study to fully understand what's going on in the heads, minds, and hearts of the MFS patients who had aortovascular manifestations. And this is with a high hope that I'll be able to help develop an intervention to support this patient group. So working with patient partners, and this is particularly the Aortic Dissection Awareness UK, we designed 4 studies to understand the effect of the diagnosis of aortovascular manifestations, as well as the effect of the aortovascular surgery in Marfan syndrome patients. The first 2 studies determined the health-related quality of life and psychosocial effects of the diagnosis of aortovascular manifestations in MFS. The third study determines the mortality and morbidity outcomes of aortovascular surgery in MFS, and this is by using existing data from the NHS England and the National Institute of Cardiovascular Outcome Research, or NICOR. Finally, the fourth study is similar to study 1, but we are looking on the health-related quality of life and psychosocial effects of the aortovascular surgery in MFS. So developing this study is not without challenges. I can recall that as a novel study, I didn't actually know where to start and how to start it. So what I've done was I visited different centers, met with the experts in various organizations, and talked to a lot of patients to determine what would be relevant to be included. And this is how I met my PPI group. So in the process, I managed to establish the Patient and Public Involvement or Engagement Group, or the PPI group, who was phenomenally helpful in designing the studies. I actually couldn't thank them enough for their constant guidance and help to make these studies a success. Some of them were actually in this call this evening. So from the bottom of my heart, I really wanted to thank you for all your help throughout these years. So particularly, the PPI group helped me in the development of the interview guide for study 2 and the design of the patient poster, which is a requirement of the confidentiality advisory group. And this poster was designed to inform potential participants and provide them the opportunity to opt out should they wish for their data not to be included in this study. The PPIE group have also been instrumental in addressing concern from CAG on the acceptability of the use of patients' identifiable information without consent due to the retrospective nature of the study. Further involvement of the PPIE group is the development of the patient and public dissemination strategies, which includes this webinar. So after 3 years of studying, I am very pleased to inform you of the important findings of study 1 and study 2. I am still currently analyzing the results of study 3 and still finishing the data collection for study 4. So hopefully I will be able to share those results in future webinars, or possibly I can write a short report in the Marfan Trust and AD UK's newsletter. So please watch this space. So from the survey results, I found that majority of the participants reported experiencing pain, fatigue, and moderate or severe depression. However, most have positive self-esteem and do not feel devalued or discriminated due to their condition, which is a very good sign. On the other hand, the health-related quality of life of MFS participants was found to be lower in comparison with the UK general population in all SF36 and EQ5D5L subscales. And these are the two questionnaires that we use to measure the health-related quality of life. So the result of the SF36 scores is presented in figure 2. And as you can see from this line graph, the blue pertains to the MFS participants' health-related quality of life scores, while the green line pertains to the UK general population health-related quality of life scores. And as you can see, there's a clear difference on their scores in all subscales of SF36, with the lowest scores noted on general health and vitality. From the semi-structured interviews in study 2, we identified 8 themes from the patient-reported health-related quality of life and psychosocial factors affecting MFS patients following aortovascular diagnosis. And these include social and self-stigma, depression, social and health anxiety, loss of personal efficacy or independence, worry in building relationship or family. And this is mostly reported by the younger generation as they worry a lot about passing the condition to their children. The next one is vital exhaustion, which includes or which is mostly related to the constant pain or fatigue that they've experienced even before the surgery. They describe it as an invisible disability and loss of self-esteem. So, unsurprisingly, a lot of these factors were also highly influenced by the effect of the Marfan condition. Therefore, I think the separation of the effect of the aortovascular manifestations with the other symptoms of MFS seems to be impossible. So out of these 8 themes, health anxiety and invisible disability were particularly highlighted in relation to aortovascular diagnosis. A significant number of participants expressed that health anxiety after the aortovascular diagnosis, since they were worried that it can get worse and may even have, they worry about having a surgery or reoperation at some point in the future. So one of them said, I would say a lot of anxiety, being tested and knowing it is very likely that I'm going to need surgery at some point. The other one said, I do have quite a lot of anxiety. I couldn't eat very well. I'm a bit worried that I potentially have a short life expectancy. I'm very anxious about my heartbeat. It can be quite bad in the sense that I can't concentrate on certain topics and worrying too much about my heart or my health. Further, they worry about the possible outcome of the potential surgery. One of them said that and this is a patient who just had surgery. And he said that it's always there at the back of my mind that something might happen to me anytime. Also, I'm always worrying about my condition. About my condition will affect me in the future. And in cases of history of aneurysm and dissection, some participants worry that they do not have any control over it, or it may have happened again eventually. One of them, I recalled, said that I think having an aneurysm especially causes a lot of anxiety. It's like walking around with a ticking time bomb in your chest. And for me, to hear that is quite heartbreaking. For some participants, the aortovascular diagnosis and its treatment could be a traumatic experience. I can recall that one of them said that I suffered with a bit of post-traumatic and anxiety disorder. A fear of something is going wrong when I started to feel palpitations. Some of the participants describe MFS and aortovascular diagnoses as invisible disabilities, since they are not well-known conditions like cancer and other chronic diseases. One of them said, I feel like Marfan is half visible, half invisible disability because I'm clearly different to other people, like I'm much taller and have other health issues. But it is not a very visible disability, like being in a wheelchair or having a well-known condition like diabetes. I feel like I'm in the worst of both worlds. As a result, MFS is not medically or legally considered a disability, which made it difficult for participants to obtain appropriate social support, both from the local and the national government. As a chronic condition, MFS and aortovascular manifestations can have a huge financial impact to participants. One said that I was struggling to find work because of my condition, because they didn't really see it as a disability. He further said that I ended up losing my job because of my aortovascular diagnosis and operation, since they don't understand my condition. They have a very negative attitude towards me a little bit because of the limitation on what I can do at work. For some participants, they were even finding it difficult to get a life or travel insurance to cover them. So one of them said that it has affected me economically. I can't even get life insurance because they won't take on someone with what I've got because they don't know about it. So I think overall listening to this, it's quite depressing, isn't it? However, on a positive note, the study also highlighted the process that the participants went through. Interestingly, some participants reported that the aortovascular diagnosis gave them the name to the problem that they were experiencing. I vividly recalled one participant said that the good thing about being diagnosed with it is that there was a name to the problem. So it can be explained. It wasn't imaginary. We know what the problem is, which is great, and I learned to get on with it. As a result, they found that the diagnosis comforting and reassuring, leading to disease and self-acceptance. So a couple of them says that it's comforting to sort of, because you have to accept it. There's nothing you can do about it. So you accept it and you live with it. And then the other one felt like it is already part of herself. And she said that I'm just so used to it now and it doesn't really impact my life that much. So the condition itself doesn't bother her despite that all the symptoms that she was experiencing. The participants also expressed that the diagnoses have strengthened the relationships with family and friends and have valued more their importance as a result of this experience. Finally, the process of receiving an aortovascular diagnosis inspired participants to be healthier and helped them to constructively engage in coping with the condition. And I think how they presented it to me when I interviewed them was really, really inspiring, because many of them verbalized that they have been healthier after the diagnosis. They made sure that they exercise, they eat healthy food, they keep themselves fit, and this is to have a reserve in case that they will need a surgery. But I think a lot of people, particularly with chronic conditions, will be able to learn from this experience of positively looking into the condition. So why are these findings important to us, particularly to us in the clinical area? So these results assist us in better understanding the health-related quality of life and psychosocial factors that affect the patients with MFS and aortovascular conditions at the same time. The information obtained will be very useful to support the development of a patient care pathway that includes this aspect of care, so we can provide a holistic and comprehensive service for this patient group. And again, as I've mentioned at the beginning, I felt that, again, as a nurse or as a clinician, we don't just provide the medical care to the patient, but most importantly, we provide and we ensure that their quality of life is good after the treatment. So what's our next steps after this study? So we will convene a roundtable discussion with all the stakeholders at the end of all the studies to develop interventions to address the psychosocial aspect of our care. We will disseminate the results through abstract presentations, newsletter, and public discussions to help increase public awareness. We are collaborating with other organizations, such as the Genetic Aortic Disorder Association in Canada, the Aortic Dissection Canada, academic institution, and other government agencies to promote knowledge mobilization and hopefully create the greatest impact. And finally, we will publish the results to provide scientific evidence, as this is the first time that it will be described in the UK population. So with this one, we're hoping that we'll be able to encourage more researchers or clinicians to focus on their study on this under-researched topic. So just a take-home message. MFS patients with aortovascular manifestations experience several health-related quality of life and psychosocial issues related to their conditions. Therefore, collaborative efforts are needed to develop interventions and programs to address their needs and provide a holistic and comprehensive service for all our patients. Thank you for listening, and I'm very happy to answer any question from the audience.
Rosalie, thank you so much. There's an awful lot in there, but what struck me was how connected you had been to patients like us, and how you have drawn out things that we are all familiar with in one way or another. Maybe we don't always have the words to express them. And I think the value of what you've done in what you've shared with us this evening, you know, it's 3 years of research in 20 minutes. That's really good going. But the value really is that you've taken what is in our heads, the things that affect our lives, and you've done the science to present it in a credible scientific way to clinicians who need it presented that way in order to take it seriously and then design interventions. And that's a huge contribution to the care of patients like us in the UK, because it's the first time it's been done. So we're truly, truly grateful for the huge effort you put in, all the sleepless nights and the travel around the world to talk to patients and organizations. I know it's been a massive effort for you. And I don't know how you've done it at the same time as working as an ICU sister at Barts, which is such a busy aortic centre. So, so really grateful, and thank you for sharing it with us. It's there's a lot in there to unpack. So we're just going to kind of move into some questions and discussion. You should have a button on your Zoom screens, ladies and gentlemen, where you can put your hand up. So if we can go into the classroom and put your hand up, if you would like to ask a question, and we'll try and spot your hand, and Victoria will help me and allow you to ask questions or comment on what we've heard from Rosalie. I'm going to change my view so I can see you all, actually. That's better. Okay. So, you know, if you'd like to comment and say, actually, that rings true with me and my life experience, or if you'd like to ask a question about any of Rosalie's slides or what she's been doing, please don't be shy. Feel free to wave your hand and start off. I've got 100 questions, but I can ask them anytime. So let's start with your chance. You've stunned everybody into silence, Rosalie. Oh, okay. We've got, so Lisa, I think that's Lisa Petty. Would you like to?
Yes.
Let's go.
Yes. Hello.
Hi, Lisa.
Hi there. Yeah, Rosalie, I just I noted that you said that it was difficult to separate the general distress of having Marfan's for these patients from, you know, the aortic side of it. I wondered if you were considering going into or recruiting patients that didn't have Marfan but had aortic disease, because that's my situation. I've got a rare gene, but I don't have a syndrome. So I had a type A dissection, but it all rang very true. The depression and the the worry. It's the same. So yeah, just my question really.
Yeah, actually, that's another, the next step that we're actually looking, hopefully we'll be able to focus as well on the general aortic patients and see whether the findings that we, or the results that we found from the Marfan's group will be very similar, you know, to the general, to the general aortic dissection patients as well. So yeah, hopefully, it's on the pipeline, it's under discussion. So hopefully we'll be able to work on that. But at the moment, because of these findings, we actually tried to develop already an intervention for the general aortic patients. And that discussion has already started at Barts, being a huge regional referral center. And we felt that some of them, even if it's not Marfan's patient, will definitely resonate to the general aortic dissection patients. And we recognize the importance of providing psychological care to them before and after the surgery.
Brilliant. Yeah. Good to hear. Thank you.
I think Caroline has a question. Far away, Caroline.
Yeah, sorry, I couldn't find the hands up option. So apologies for that. But I've had a lot of surgery at the Royal Barts, and it was incredibly traumatic. And I'm just glad that there's some research going into this area, because my daughter has the same condition. And one thing I didn't realize, I didn't think about it. I thought, well, it's all right because I'll be there to support her when she's going through it. So she won't be alone. I'll be there to hold her hand. And then I realized, because of the medication, we've moved on with medication. So the likelihood of her having to have these treatments means it will be further along in her life. And I realized that I could be dead by then. So who's going to support her when she's going through the trauma that I've been through? So I really appreciate the fact that you're looking into this, because I've had my whole aorta replaced now. It's a very big operation. It's difficult to go through, and I always thought I would be there for my daughter, but it's suddenly realized, I mean, it's a good thing that things are being moved back and the medication's there, but there wasn't that mental support. And as I said, I was a single mum, so it's a worry. I didn't have any support. I'm not going to go on too much, but I'm just glad that you're recognizing that that's the mental side of it is just as important, and that hidden disability side as well.
That's right. So you're absolutely right, and I think again, as a result of this study, our quest, to further request for the need of psychological care and psychological support to the patient has been strengthened because of this study. As I've said earlier on, it's already in the discussion at BARTS that, we need to provide rehabilitation and rehabilitation on the psychosocial aspect of care.
Thank you. That's right. Karen, that's a really, really good comment and question. And I can relate to that because I have a son who has Marfan Syndrome. So my dad died of a dissection from Marfan Syndrome. I had the same dissection at the same age, and Bart saved my life with major surgery. And so, of course, we worry about our children and what course the disease is going to take in them. And that's quite a significant anxiety for those of us who are parents in that situation. Rosie, did that come out at all in your research? People worrying about their children?
Oh, yes, definitely. So it's highlighted on study 2 that they worry about building a family, or this is for the younger generation, building a family and having a relationship, because they don't want to have children because they're worried that they're gonna pass the condition to their children. But then again, those who have children, as you said, they particularly worry that the same as your condition, that they're worried that the same experience will be experienced by their children.
Exactly.
So that's why when they come to the hospital, they're already like very anxious. And I think that that will be particularly highlighted in in study 4, because when I look on those patients who were having surgery, study 4 is looking on the health-related quality of life effects of the aorto-vascular surgery itself. And that's what's the common complaint, or things that always being verbalized by those patients for surgery, that they are worried that, oh, I've got a son or a daughter, and I'm worried that they're gonna have the same surgery as I am, and I don't want them to go through the same process.
Exactly. But I would also like to put forward that you said about worrying about the future, and it's mainly the young people worrying about families, and that I have to say that I've suffered a lot of depression because I'm looking forward. As I said, I'm a single mum, and I don't want to go out there looking for another partner or anything, because I think, well, what have I got to offer, because I have all these health issues, and that causes a degree of, so it happens because of the social dynamics these days. It's not as simple as boy meets girl, boy marries girl, boy has children, they all live happy ever after. Things go wrong, and there's older people in the same situation as younger people thinking, how do I move on for this? Have I got a future? The ticking time bomb thing. Yes, I've had my whole aorta replaced, so I'm feeling happier because I don't have an aneurysm to worry about, because that was a very worrying period. But it's it's still a significant health problem.
Thank you. I think it is a lifelong condition. We've got a number of people in our charity who've had their whole aorta replaced now. I haven't. I've had 2 sections replaced, which is quite enough surgery, actually. So I'm holding it as long as I can. But I always joke with Onwu, the professor of cardiothoracic surgery at Bart. I said he hasn't had a chance to operate on me yet, but he follows me around in the hope that one day he'll be able to.
the prof did mine, and he was amazing. And
Yeah.
so,
Yeah.
yeah,
So I think when you've been repaired that well by a team like that, and you've had your whole aorta repaired, yeah, that's great. You're fixed. There's nothing to go wrong with the aorta when that's happened.
no, there's other bits that can go wrong. That's the problem.
There are other bits because it's a syndrome. But the other thing is, those of us who are parents worrying about our children, what I've learned is their experience of the disease is not the same as ours because of research and advancements in medicine and surgery. And Dr. Anne Kyle, who's the medical director of Marfan's, always says that 30 years of research in Marfan syndrome have delivered 30 years increase in life expectancy. So I keep having to remind myself that my son's experience of this disease is not going to be my experience. And in all likelihood, a dissection in him will be prevented one way or another because the research we're doing is transforming the disease. So I find that quite encouraging, actually.
Absolutely. And my daughter, bizarrely, has already had a conversation. She's only 19, about to be 20. She's already had a conversation with her current boyfriend about how she's probably going to have a surrogate mother because she's not going to go through it and a childbirth and have the problems I've got. So she's a lot more aware. She's a lot more prepared. She's a lot more ready for it than I ever was.
Excellent, thank you. I can see that Suzanne Swift has got a question. Suzanne, would you like to ask your question, please?
Yes.
Oh, it's not Suzanne, it's Glyn.
Yeah, sorry. Yeah, it's Glyn Swift. I have Marfan syndrome, as do most of the rest of you. The thing you were saying about children, I found really interesting. I got diagnosed when I was 15, by a counsellor coming around my house telling me I'd be dead by the time I was 35. She was clumsy. It was deepest, darkest Wales. And my mum went for it. Aside from that, I'm 44 now, nearly 45. Had aortic surgery about 18 months ago. Found out I was going to have it right at the start of lockdown. And that was quite hard. Like hiding away, like thinking you were going to, if you catch stuff, you're going to, and then coming out, like having surgery towards, about 18 months ago, and then coming out and feeling the same social anxieties. That's the last 3 years was really challenging.
Yeah.
But what you were saying about sort of siblings, my son is 14 on Friday. He has Marfan syndrome, same as me. He was born with it. Diagnosed at 3 months. His aorta was massive. They diagnosed him with neonatal Marfan syndrome, which was new to me. By the time he was 7, had his whole aorta replaced, had a NUSBA, had a valve and a mitral valve. So to hear people talk about it, mad, very cool. And it is flipping hard,
Yeah, that's a really, I think it's a really challenging thing, isn't it? And watching someone you love go through this is harder than going through it yourself, I think.
Yeah, when you didn't realize that it could be so much worse. Like he's a wheelchair user now. Yeah.
Oh, well, thank you for sharing. I guess the question to Rosalie I would ask in that situation is, Rosalie, if these interventions that we anticipate might come out of your research, obviously they will be targeted at the patient at the point of diagnosis. But as Glyn says, the family is often very seriously affected by the diagnosis as well. Do you think the interventions will embrace the effect on the family?
Well, that is very good point, Garrett. And again, that is the limitation of my study, that I didn't include the family in the whole study. but it came out that, yeah, the effect on the family is really huge as well. So I think as part of our roundtable discussion, then definitely we'll be able to include that as part of our, intervention development, to include both as a to truly provide a holistic care to these patients. We need to include not just the patients but their family as well.
Yeah, okay. My experience was very similar to Glyn's. I was in deepest, darkest Wales. My dad had a dissection. I was 11 years old, and somebody came around and showed me a piece of literature that said your life expectancy is 32 plus or minus 16 years.
Yeah.
And that was about the level of, and if ever you get sharp chest pain, go to A&E. That was the advice. So I think things have moved on since then, unfortunately, and there's a lot more awareness.
Yeah.
But I think at that time, as an 11-year-old, I would have really valued some kind of psychosocial intervention to help me deal with what was going on. My dad dying of a dissection and me being told I was at risk of the same thing. So if that can be part of the roundtable discussions, that will be brilliant.
Absolutely.
Thanks.
Natasha has her hand raised.
Yes.
Natasha Duggan.
Yes, Natasha.
Hi there. Hello.
Hi.
Can you hear me?
Yes.
Hi.
Yes.
Hi, Gareth. Yeah, I'm sorry I came to the discussion late, so I might be kind of repeating something. But like Gareth, actually, I was diagnosed at an early age, and then I lost my mother when I was 15. So, yeah, this is an amazing kind of just having this space to know that this is the research is going into the psychological side of things is amazing, because I was just wondering about whether any PTSD was diagnosed with anybody that anybody that was studied that contributed. I maybe missed that, but
I think one of them, quite a few actually, not just one. Quite a few have a PTSD, particularly when they had the surgery. So they were all very scared that even, a palpitation or just an increase in their heart rate, they feel like they're gonna have a cardiac arrest or they're gonna die. And that's why one of the worries was that was highlighted was health anxiety. So even if it's already been repaired, as Gareth says, that once it's repaired, most likely it's been repaired, then
lowers the
most
risk.
likely lowers the risk of of any further emergency condition. But then again, because of the trauma that it created or it gives them, it's just in their mind that anything might happen, even if we constantly tell to them that it's already been repaired. When they feel that there is an increased heart rate in particular, this is what they keep saying, or they kind of felt like they're having shortness of breath. They felt like something will happen to them, and then they'll go back again to zero. So that and this is also particularly noted in patients who had aneurysm or aortic dissection. So they are really, really terrified that they will have another episode or blackout or whatever. So it was very common.
Thank you, Natasha. That's a very good question. Rosie, just as a follow-up to that, can I ask you, you've talked about health anxiety, you've talked about depression. Natasha's raised PTSD, which I think stands for post-traumatic stress.
Post-traumatic stress.
Would you just for the benefit of everybody on here, would you just like to say what's the difference between those three things, and is there any difference as a health professional in terms of how you deal with them?
So the difference between the three, you mean?
Yes.
So so the PTSD is when they've been diagnosed with trauma as a result, or having some trauma as a result of an incident. So for example, the aortic dissection, for example, could be an incident, and undergoing the surgery is again another incident related to the aortic dissection. And because of that, they have develop trauma as a result. So that is what PTSD is. Now with the health anxiety, so we coined it. So in general literature, it is very common, apparently, that or from previous studies, that patients with Marfan's, again, there was no study about patients with aortovascular manifestations, but particularly just in Marfan's in general, that Marfan's are very anxious because of the, the associated condition related to the syndrome.
Mm-hmm.
But in particular, I have identified in the study, there is a particular health anxiety when they have aortovascular diagnosis. And that is because, as I've said earlier on, when they were diagnosed that something is wrong with their heart. So even if they're still being monitored, so as you probably, most of you who have, if some of you will have aortic manifestations or aortovascular manifestations, you will know that you're being monitored almost every year or every 6 months, most frequent, to determine whether the size of the aneurysm or the enlargement of the aorta is getting big. And that will determine whether you will require a treatment or a surgery. So even if they're only on that stage that we are just monitoring them, the mere fact that they know that they've got a heart problem and they might have, a dissection at any time, or a possible dissection at any time. So a slight increase in their heart rate just make them really anxious that they might die, or they might have goes into cardiac arrest. And that is the health anxiety. And I think for your your last question about how we're going to be dealing with this. So this is the thing that we're trying to develop, the intervention on how we're going to be addressing this. Obviously, for me, as a health professional, my quick answer will be the psychosocial or psychological care, talking to the patient, etc. But it may not be the appropriate, may not be the appropriate intervention straight away, because yes, we're talking to you, but then again, the anxiety is always with you. So I'm thinking another way of, and this is again another project that we're trying to collaborate with Brock's University in Canada, is to develop an intervention for knowledge mobilization about the symptoms of aortic dissection. And we're thinking that, again, this is just on a planning stage, and we're thinking that if we're going to be able to increase the knowledge of the people with aortic dissection or aortovascular manifestations, and we can tell them the exact symptoms, or what's happening or what's going to happen to the patient, similar to a patient who, for example, most commonly, like patient with MI, for example, and if we can tell them the symptoms and then what they can do, then hopefully that would lessen their anxiety if they feel a chest pain or an increase in heart rate. So that's one of the interventions that we're trying to hopefully develop, and to increase their knowledge about all these symptoms, for them to feel more relaxed. When they feel that, it doesn't necessarily mean that they're going to have a cardiac arrest or they're going to die straight away. So there will be a symptoms that they can feel, and we can tell them what they need to do in case of those symptoms. So I hope I answered that question.
No, that's good. Thank you. I'm sorry to put you on the spot, but yeah, that's exactly
No, that's fine.
That's exactly why we do what we do in aortic dissection awareness, because we find that awareness and information, knowledge, empowers patients to take control of their condition and be less anxious about it. So
absolutely.
I noticed that my good friend Lindsay Rouge, who leads the Think Aorta Canada campaign, is on the call. She'd be really interested to talk to you about that, I'm sure. With a data angle. Caroline has another question. Caroline, go ahead, please.
Sorry, I just it comes into the head and disability though as well. The post-traumatic stress, if you've had worries about your condition, and you've had treatment for your condition, you can become then very sensitive to going into hospitals and dealing with that. But because it's post-traumatic stress doesn't necessarily relate to those situations. And I feel a bit silly saying, after my operation, I think I've got a bit of post-traumatic stress, because you associate it with war heroes and things.
Yeah.
And I feel almost guilt for saying, I'm sorry, I'm going to have a problem with this appointment at the doctor's because I've got a bit of stress about this sort of situation. So it is about that hidden disability, that it all sort of, you've got this worry going on.
That's true.
And people don't necessarily realize that's going on in the background. And that's what I was just wanted to pick up. That's great that you realize it is a hidden disability. It doesn't necessarily mean we're all disabled or struggling. It just means that there's something going on with us that is actually affecting our lives and what we're going through.
Very much so.
Absolutely. Absolutely.
Thank you. I've got a few hands up. Anna, would you like to ask your question next, and then Ruth? Hi, Anna.
Thank
welcome.
you. I found the hand up eventually. Thank you for that presentation. I found it really interesting. I just wanted to share sort of a bit around my experience and how actually my experience psychologically has changed through different points of my life, because I'd say I'm probably approaching a point where I may need cardiac surgery. But if I compare how I am now to 15, 20 years ago, when I was a teenager, I knew I had Marfan's, but I was quite reckless. And I think there's no one else in my family who had it. And I wanted to live like a teenager and have those experiences. So I think it'd be really interesting that actually people's experiences may change as they go through their life. And now I'm a parent myself. I am much more sensible with what I do. But there was definitely a period of time where, you know, I felt like I was pushing against my diagnosis, and I wanted to experience my life and do all those things that teenagers do without the label, without everything that I knew would have come at some stage. So yeah, it's not necessarily one feeling the whole time. I would say it definitely changes as you go through different parts of your life.
Yeah.
Thank you for sharing that.
Yeah, it's a very important point, I think. I mean, Anna and I have compared notes before about our lives with Marfan Syndrome, and talked about the things that we didn't tell our mums when we were teenagers that we were doing. You know, but you do. I think one's attitude is very different, and in your 20s, you just want to get on with life. And so my experience was that Marfan sort of kicked me in the teeth with something acute every 10 years, but in between, I was pretty much all right and could pretend to the world that I didn't really have a problem until I had my dissection. And then when the aortic stuff really hit me, that was the life-changing time, and was the time when I had to do the most psychological adjustment, actually. So that's why I like what Rosalie's done with Marfan's and Aorto-Vascular diagnosis, because I think it is, in a Marfan's life, that is a really big deal. You know? Yeah. Thank you, Anna. That's a really good point to make. Ruth, can I move on to you, please? You'll need to unmute yourself.
Okay, thank you. And thanks, a really interesting talk, Rosalie. And I think quite a lot of the questions I've had in my head, people have raised, and that's really helpful. And you started to talk a bit about the things that are interventions to support, I suppose, health anxiety, and that there are, and I suppose I wanted to hear a bit more about that. And I also had a little example from my own experience. I've had an aortic dissection a year ago, I haven't got Marfan syndrome. So I suppose there's obviously a very different experience if you're growing up with something that you know might happen, or you have experienced family members. But I was wanting to hear a little bit more if you had any more the idea of health anxiety. But I suppose one of the things that I'd found was having a watch that showed my heart rate, because it's interesting, I think, from my experience, becoming more aware of what's happening in my body and much more sensitized to that. And what's really interesting is the times that I might have thought it was going really fast. Actually, when I checked on my watch, it wasn't. It was actually within a very ordinary and a good low range. And so having using some sort of technology to help feedback for some of those, the things that you were talking about, basic heart rate perception and what's happening, are things that I suppose are already out there. But I guess there's a whole load of things that can be developed to do with us tuning into our bodies. But of course, that's different if you're talking about a syndrome over a lifetime and adjusting to that. But so I'll let you answer the question, which is what other things are being, developed?
Well, at the moment, we don't have yet. So because the study hasn't completely finished. So actually, that's the next step. That's why I've highlighted it. What's going to be the next step? Because again, we need to develop the interventions together with all the stakeholders, because it's not, again, this is from my experience as a researcher, that it's going to be pointless me developing one that is not useful for the patient. So I wanted the patient to be involved and all the stakeholders to be involved in the development of these interventions. And I think what you have suggested of having some sort of a technology will be a very, very useful example of a potential intervention that we can, develop for our patient. But at the moment, we haven't decided what intervention we're actually going to be doing. But as I've said earlier on, the discussion of the need for the psychological support is definitely been highlighted already at BARTS, and they've already, the people on the higher management team has already recognized that there is a need, and so we just need to push for that, and hopefully we will be supported for all the interventions that we're going to be developing. But if you have any other ideas and you would like us to consider, please do contact us, me and Garrett, and the Marfan Trust, if you would like to pass on any ideas to us, and that would be really, really appreciated. That will help us to develop more interventions for our patients.
I think technology does offer a lot of options, and one of the things I'll mention, Rosalie, just because I like the fact that BARTS are doing it, is at the moment they've got a pilot project with an aortic app on your mobile phone.
Yes.
And if you're an aortic patient, you get this. You can put your blood pressure in. You can communicate with your aortic specialist nurse. And I think, I don't know, as we looked at the psychosocial impact of having that, I imagine it must be very positive.
And sorry, my screen froze, so I missed a bit earlier on, but I think also the information. So,
oh yeah, you're frozen again.
She's frozen. Yeah, I think that's a very while we're waiting for her to come back, I think it is a very, very good point, Garrett, for that Ortus. I'm actually I'm going to present the result of our Ortus app in the conference in ACNAP in Poland in June. And it's a very good point that that's something that we can, as a next step for that intervention, we can potentially evaluate, the psychosocial effect or the psychological effect of that app to the patient. So maybe, as you said, it may be able to help them, relax a little bit if they know that they are being monitored, or they can contact us straight away if they put in the details that, blood pressure and heart rate and stuff like that.
Yeah, super. Thank you. That's a really good innovation, and I'm very pleased to see. But there's lots of good stuff going on in BARTS. I can say this because I'm a BARTS patient. I think they're the best aortic centre in the country, and they're doing a lot of great stuff. So, look, we're out of time, ladies and gents. That's been a really good discussion, and I hope it's given you a lot of food for thought. Rosalie, thank you for being put on the spot and answering all those questions. Thank you to everybody who's shared their experience, made a comment or asked a question. It's been a really positive conversation for all of us. And for those of you who've just listened, I know you will have benefited too, just from hearing other people's experiences and insights. So it's been a great session. I'm very grateful to Victoria, my partner in crime, and the Marfan Trust for putting on this webinar. It will be recorded. Both charities will share the recording, so you can watch it again. You can share it with your friends and your families, in order to share the love, as it were. I did forget to mention one key person, and my good friend Darren McDean, who's on, likes to sort of sit behind the scenes, but he helped both Marfan Trust and AD Awareness to put this event together, and he designed the flyer for us that you've all seen and clicked on to register. So Darren, thank you, mate, for doing that. It was a really important contribution, and I'm sure that the number of people we've got down here is in some part down to the quality of the flyer and your wonderful eye for it, which I don't have. So, so thanks for doing that. Two things to say. I think, Victoria, the next sort of big in-person event the Marfan Trust is doing is a patient day on the 31st of August in London. Is that right?
The 31st of August, it's a four-way collaboration with like-minded charities, Marfan Foundation, Aortic Dissection Charitable Trust, and Annabelle's Challenge, which represents vascular Ehlers-Danios.
Yeah, so it's for Marfan's, Loeys-Dietz and vascular Ehlers-Danios syndrome patients and families. Victoria's very kindly invited me to speak about how to self-advocate in Marfan syndrome. So if you're not fed up of me already, you might want to come and listen to that. And so that's on Saturday, 31st of August. Have a look at the Marfan Trust website. And if you can get along to it, it'll be a really good day.
It's a family-friendly day with a children's playroom. Everyone is welcome. It's going to be stupendous. Yeah,
fantastic. So watch out for that one. And we will, I think, plan some more joint webinars in the future. So watch out for news of those. And you're always very welcome to come back and have a discussion like this with us. So thank you all very much. Have a great rest of your evening, and hope to see you again soon.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Bye, everyone.